Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, September 19, 2024, we are speaking with Dr. Carolyn Chu and Dr. Lealah Pollock. Dr. Chu is professor of clinical family and community medicine at the University of California, San Francisco. She is also the chief clinical officer of the National Clinician Consultation Center, which offers guidance to healthcare providers on HIV, hepatitis, and substance use. Dr. Pollock is associate professor of family and community medicine at the University of California, San Francisco. She is a family physician and HIV provider with a particular interest in sexual and reproductive health for women and birthing people living with HIV. Today, Dr. Chu and Dr. Pollock join us to talk about what's hot from the warm line, top 10 questions from HIV clinicians. Carolyn and Lealah, welcome to the podcast.
Thank you so much for having us.
Thank you.
Great.
We are
Yeah.
delighted.
This is going to be really good because I remember the initial start of the warm line with Dr. Ron Goldsmith, who sadly passed away a couple years ago. But what a force of nature he was, and what vision he had to get this started. Were you all a part of the warm line going back that far, or when did you all start getting involved?
I can try to start. Yes, we are still grieving the loss of our founder and director Ron. Not too long ago, actually, it was this summer. But yeah, I joined the NCCC in 2015 as its clinical director, and then sort of stepped into my current role. So I have been here for maybe about a third of the NCCC's life, because the NCCC has been going for about 3 decades now.
Yeah, and it I remember it starting in either the late 80s or early 90s, and back then there wasn't a lot of choices for antiretroviral therapy, and there was a lot of death and dying and a lot of other issues going on, and clinicians needed a place to go for reliable information, and this was kind of a oasis for folks who were kind of wandering around in the desert, looking for solid information that was reliable and that was patient-centric for the clinicians taking care of folks. So you guys have been involved for a while. The tradition continues, and I'm real excited to hear from you all in terms of what's new. So I don't know of a great way to do this except just turn it over to you guys. I'll start with, what is, in your all's estimate, the top type of question that you all get these days?
So our services have expanded over the last 30 years since Ron founded the Warm Line. It's been about 18 or 19 years ago now that he started the perinatal HIV hotline with Dr. Deb Cohan, and I have the great honor of being the director now of Women's and Children's Consultation Services here at the NCCC. We also have a dedicated hepatitis C consultation line. PrEP line, a PEP line, and a substance use warm line. And so have really been able to expand the scope of consultations that we take, the scope of questions that we answer, and really take calls from clinicians of all experience levels from across the country. And I can...
Do you all provide advice to people wanting to bet on college football? That's off bound. No.
Not in
Only
California.
if there was a needle stick involved.
So what would you say is the top question? What I'm sure there's more than one.
Well, yeah, Lealah, do you want to start maybe, because I think one of the many things that makes the perinatal hotline quite special is that that's our 24/7 line. So we're getting calls on that line outside of the sort of other warm line hours, but there's many interesting questions coming through the perinatal hotline. Maybe Lealah, you can start us off with that.
Yeah, absolutely. The we get questions about care of pregnant people and with HIV and their infants throughout, from preconception to through pregnancy to delivery to care of the HIV exposed infant. Um, and the one of the most common topics that we're getting calls about now is about infant feeding for people with HIV, and particularly about supporting people in breastfeeding or chest feeding their babies. Conversation questions about how to have those conversations during pregnancy. A lot of questions about care for babies who are breast or chest fed by people living with HIV, questions about testing, about prophylaxis. It's a really major and important change in the guidelines in the United States, both from the CDC, from the Department of Health and Human Services, and most recently from the American Academy of Pediatrics, really saying that we should support people with HIV to choose how they want to feed their babies. Um,
Right. So let me dig in here. So I'm a caller right now, and I say I have a patient of mine who just delivered a baby. She would like to chest feed. She'd like to give natural, if you will, feeding to her newborn. The woman, let's say, has always been undetectable. She's on a bictegravir-based regimen. Should she do it?
Yeah, so what I would say really is to have a conversation with the patient about their desires. And a couple of questions I would ask is, one is, did this patient have the opportunity to have these conversations already prenatally, or is this kind of the first time it's coming up in their care? Because if this is a conversation that they've had during their prenatal care, they've sort of come up with a plan with their providers, there's no need to revisit it on labor and delivery. And we can just talk about how to support her, how to get a lactation specialist to see her to make sure that she has a good latch and maybe goes home with a breast pump, um, those sorts of things. If this is,
So those are the usual things that uh, be true for a person with HIV as others. But what's the unique question, or what? Why would I want to have a conversation? Why wouldn't I just say, "Yeah, it's great. Go ahead and breastfeed because you're undetectable and you've always been that way."
yeah, absolutely. So the thing that we want to make sure that we say to patients in our counseling is that we have not yet reached a place with breastfeeding or chest feeding where we can say undetectable equals untransmittable. So we know that the risk of transmission through human milk in the setting of ART and an undetectable viral load is extremely low. We know it's less than 1%, likely far less than 1%, but there have been cases of HIV transmission in the setting of ART and an undetectable viral load. That is with like starting ART late in the third trimester or at delivery. So it's not quite the same, but we just don't have the data on the sort of patient that you're describing. So we need to have that conversation of like, the risk is really low, but we can't say it's zero. We know that there are benefits to breastfeeding or chest feeding. how how are you thinking about this? What's important to you? um, how do you want to approach this, and let's have a conversation. And so it's really
Right.
not, it's hard. It's not kind of the line with people without HIV of breast is best, we want everyone to breastfeed, and it's not the line that we used to have of people with HIV can't breastfeed and they need to formula feed. And so it's really figuring out how to have those patient-centered conversations.
It's really interesting because back in the day before we had antiretroviral therapy, correct me if I'm wrong, the risk of transmission without the cover of antiretroviral therapy ranged between 3 and 6%, roughly. Not quite the same as at the time of birth, but significant,
Hmm.
right? And then in sub-Saharan Africa, they actually led the U.S. and more developed countries, right?
Hmm.
Because the women really insisted on it, even especially when they were undetectable. And then it became kind of the way forward. It's kind of the rule of the road in sub-Saharan Africa. But the U.S. and Europe are a little bit more cautious about discussing risk, which, as you described. So, summarizing, it sounds like if mom is comfortable with that less than 1% risk and the meaning is there, then you would give it a thumbs up to go ahead,
Hmm.
right?
Absolutely.
Okay.
Yeah.
And then what's your advice to women who are pregnant or just become pregnant? They're already on an antiretroviral regimen. Do you want them to switch to a dolutegravir-based regimen if they're already on an integrase inhibitor like bictegravir? Do you tell them just continue with what you're on? What's your current thinking?
Yeah, in general, if people are on something and they like it and it's working well, and we don't have any data to say that it's going to be harmful, I kind of say, you know what, it's working for you. Let's not rock the boat. Pregnancy can be really hard in a lot of other ways. Let's just continue what's working. If somebody says to me, I want to be on the regimen that has the most data in pregnancy, right now, the regimen that probably has the most data to support its safety in pregnancy is dolutegravir plus tenofovir alafenamide and emtricitabine. But we are getting more and more data about Bic- bictegravir, and that the recommend that data is going to be incorporated into the next set of guidelines, and likely we're going to see a lot more support for not just continuing but actually starting bictegravir in pregnancy.
So I should have asked this earlier, but is it patients calling your warm line, or is it physicians only, or nurse practitioners or providers?
Yeah, it's any provider who's
Okay.
in the U.S. or sort of has a U.S. affiliation. And I was actually going to offer sort of a curveball or add to what Lealah was describing. I think, some of the questions that are actually coming up around long-acting injectable ART, we've actually had some of those calls come through our hotline, but also on our HIV warm line. I mean, it's very much the sort of cross-cutting interest in just sort of like where the treatment paradigms are going right now. I
Yeah.
would say
So
that's actually another
that's a
somewhere in
top
the top
10.
10.
So,
Yes.
so what do you say if somebody's already on cabotegravir with rilpivirine injectable? Um, my understanding of those data that there's really not enough data and recommend coming off. That's what I would think. But is that what you're saying?
Part of the issue is that they're so long acting that actually if you stop them when you find out that somebody's pregnant, they're going to have exposure to it through most of their pregnancy anyway. And there's not good guidance on if somebody wants to get pregnant, exactly when they would need to stop before conception. Um, and often people are on injectable ART for a reason, that they have maybe struggled with taking pills in the past, or um, yeah, or have a reason why they haven't wanted to take pills. So in general, if somebody becomes pregnant on cabotegravir or rilpivirine long-acting injectable, then we say, there's not a lot of benefit to switching at this point. I don't know, Dr. Chu, if you have anything to add.
Yeah, I mean it's hard because the data aren't there right now, but I think one of the mantras that we have across our warm lines is really like it's options, not answers. I mean, because the people who are calling us are the providers. I mean, we're just trying to support them and sort of their thinking and how they can have conversations with their patients. And usually, more often than not, there will be options. And now there's an additional layer of options, if you will, with the long-acting injectables. So very rarely is there sort of like one right way to go, honestly.
Yeah. So I'm thinking we might want to name this podcast "Warm Line in the Gray Zone."
Yeah,
Yes.
that's most of what we do. And
This
it
is a
makes it
data-free
interesting.
zone.
It makes it fun and interesting. Yeah.
Yeah. So, Carolyn, what are the top couple things that outside of perinatal questions? What are the things you're encountering?
Oh, yeah, I mean, I can try to sort of finish the line of thought as far as long-acting ARVs. I mean, I think, we're continuing to get questions around, quote unquote eligibility for long-acting and really digging into very interesting questions around resistance. Sort of like what is the best approach to, assessing what someone's HIV drug resistance history might look like. And we know how hard it is sometimes, to get those historical records or to really dig through the charts and get a full sense of what someone's treatment history is. But I mean, we encourage people to do that given that, we're still in early days with kind of rolling out long-acting cabrilpivirine. And now that lenacapavir is available, those are additional questions that are coming up. Okay, well, when would I consider Len? When will that be a benefit? When might not? When would it maybe not be necessary? Um, and I think with particularly Cabril, I mean, then we're also trying to do our part with reminding folks around the hepatitis B issue, given the prevalence of hepatitis B and HIV co-infection, and the fact that Cabril is one of a couple two-drug regimens that really wouldn't offer too much hepatitis B coverage.
Right. So if I'm calling in and I'm saying I've got a patient who I inherited from, who've been on treatment for many years, and they really want to go on cabreltegravir, they don't recall uh, having any drug resistance, but that maybe they did. You don't have access to records. Do you recommend getting a DNA assessment of resistance using a DNA assay if they're undetectable?
Um, we at the NCCC don't have like a standard, like you must do that. I think we are really looking at our work as offering information. And I think, we are aware of, the guidelines language around, what the role may or may not be around DNA genotypes. And I think it's an interest area of mine. And I think if you're going to get it, I think you want to pause and ask yourself, well, what will I do with this information? And what's important is that I need to know how to interpret this information in the clinical context. So, ordering that for someone who's been virally suppressed for years is very different than if I were ordering it with, low level viremia, for example. And, having the patient's treatment history is actually going to help potentially like how we interpret those DNA results.
Yeah, and my personal view, for whatever that's worth, is that the DNA assessment doesn't tell you if whatever you're detecting is in a viable full-length virus, and that's where we
Exactly.
get tripped up, right? So, what are some other common things? I imagine interpreting resistance mutations would be a common one.
Very much so. Very much so. Yes, and I think a fair number of callers, especially if they might be pretty experienced, they will be aware of other resources. For example, I know the IAS-USA maintains a list of mutations, and Stanford database is very accessible as well. But I think sometimes it's really just kind of putting it all together. Which mutations are the ones that I need to be a little bit more cautious about than others, or just how will this ultimately impact my ARV decision making and thinking. Yes, resistance and ART changes, I would
Yeah,
say, is the vast majority of our HIV warm line calls.
And the other,
right. And go ahead.
I was just going to say, just to add to what Carolyn was saying, I think the other piece along this line of we offer options is thinking about how to use those resistance testing results, not just in the context of their treatment history, but also in the context of sort of their life and their desires and sort of what's important to them and what they're kind of willing and able to take, and helping provide. Ideally, we help provide sort of a couple of different regimen options that the provider could then take back and think about themselves or present to the patient, so that they feel like they have some choices to bring back to the patient.
And I imagine I can see the great value in what you guys do and getting into the weeds with physicians and providers um, about their specific issues. Do you give them an invite to call back and some follow up questions? And if they do you try to get back with the same person they talked to on the warm line earlier?
Yeah, definitely. I think we try to make our program really as easy to access as possible. We're free. It's all you need is a phone, literally, to call any of our toll free numbers. And yes, we love really having that follow-up information. Actually, we have been sort of piloting what we call our EHE follow-up project, where we've been able to sort of identify a sample of calls where we offer ART options, and we're actually sort of making sure with the provider that we can actually follow up with them in a couple weeks to see, did you make this change? How did it go with your patient when you offered it to them? Were you able to check a repeat viral load? Has it gone down? And I think that has been a very exciting project for us to actually start doing, so that we can get a better sense of some of our outcomes and how things are going.
Yeah, I was just thinking that how much of your follow up might be by email versus phone call?
That is a good question. There is a way for us to send sort of an automated email just as a reminder, hey, we talked on such and such a day, but it's a very general email, and we have found that having that sort of phone-based conversation is actually a lot richer, just to be able to really talk through some of the nuance. And because we're an educational resource, we do not have any patient identifying information. We actually have no access to a caller's EHR or anything like that. So,
Good.
so it's really just that, looking through it with the educational lens.
Yeah, that makes a lot of sense to me. What are you saying about PrEP these days? I mean, you got a lot of options: the tenofovir with FTC or TAF with FTC, um, but now you also have cabotegravir injectable and these new data that have just come out on lenacapavir every 6 months. Um, what are you? I know you're going to have a conversation and know about the individual, but let's say I'm calling and saying the patient doesn't want to take any pills, and I'm debating between injectable cabotegravir every 2 months versus I really would like to use a sub-Q lenacapavir. What do you say to them?
We're all,
Lealah, do you want to
yeah,
start?
we're
Yeah.
all very excited, looking forward to the FDA review and hopefully approval of lenacapavir for PrEP. One big issue I would say that I am still hearing a lot from callers on the lines is just access to injectable PrEP. They're still pretty limited in terms of programs around the country, and especially callers who are calling us from rural areas. Who have patients who are interested in being on injectable PrEP. Um, a lot of them are not in health centers that are offering that, and depending on sort of where the patient is and what their insurance is, it still is a barrier, and I think it's going to be an important challenge to overcome with lenacapavir too, is making sure that it's something that is accessible and affordable to patients across the country and internationally as well.
Yeah. So you're going to wait, it sounds like, for FDA approval before you'll start giving people a green light. First off, it might not be get paid for it until it's FDA approved. The original data, just to review for folks, was on cisgender women who had a virtually almost 100% protection versus the TDF or TAF FTC control. And now the second study results just kind of came out in press release form, showing that for MSM transgender women, that it's actually almost the same efficacy, maybe a couple of breakthroughs, but for the most part, close to 99+% protective. So every 6 months sub-Q injection feels very um, easy to me. But you're going to probably wait till FDA approval before you'll start pushing that as an approach.
I think that getting it paid for is before then is going to be a big issue. I think potentially there could be situations um, of get like before it was approved, fully approved for HIV treatment, that we were using it for compassionate, sort of getting it through compassionate care use programs. But I don't know, Carolyn, if you have any other thoughts or experiences with it.
Yeah, no, I mean, I think I'm really curious sort of how the infrastructure is going to be built around this all, honestly, to be able to really increase access. I feel like the long-acting cab rollout, hopefully we can take some lessons from, sort of what happened and see what we can avoid, see what doesn't feel like, see maybe there's things that were unavoidable. I'm not sure, but I think access is huge. Having more options is good, and one of the things we probably don't talk about as much as we could around PrEP is this idea that it's a lot more fluid than I think any of us really think. And so when we're doing these initial PrEP visits and counseling, maybe part of the message needs to be, okay, right now in your life, maybe the oral option feels right to you, and let us know,
Mhm.
stay in touch with us. Let us know how this experience works for you. But in the future, like, it could be something else. So to me, like, that feels like a very, common practical way to think about PrEP continuity. We know how we know how significant the drop-offs are. We've seen the PrEP persistence data, and it's not super encouraging, I would say. And so having more options, making sure that we're building new access points, making sure that we're understanding what people want in their PrEP, to me, that those are the conversations we should be continuing to pay attention to.
I think also, taking lessons. I mean, we on the at the NCCC are providing individual provider consultation, and I think um, we are able to hear a lot of things from what we hear on the lines that I think have sort of public health and sort of health system implications. And one thing I think with lenacapavir too is thinking about sort of lessons from the family planning world and using sort of the success with doing sub-Q self-administered Depo-Provera, both in the United States and internationally. And is that something that we can learn from, where we mail people an at-home HIV testing kit and their lenacapavir dose? Are there ways to really make it low barrier and accessible?
Yeah. As I expected, our time is flying by. I also was just imagining that another common question you get is about post exposure prophylaxis to STIs with doxycycline. And you all get that question, I imagine. So, what do you advise there? Or do you have the same rules that your colleague Anna Luchtenmeyer says? She's fairly broad in her suggestions. We have a podcast with her for folks who want to reference that. But real quickly, if somebody says, I've got a person and they've had, let's say, 2 episodes of an STI in the last 6 months, what do you think about me prescribing post exposure doxy?
We are getting those questions. Our post-exposure hotline remains focused on HIV and Hep C and Hep B, but certainly I think we've been excited about the DoxyPep data, and I think a lot of the CDC-funded PTC networks are actually really rolling out training. So we think it's extraordinary that it's available. We know that there are a lot of unanswered questions, and I think the CDC and health departments are really trying to update the communications to providers very regularly so providers feel confident about what the science shows and how they can do this in practice.
And I'd be remiss if this is probably a good one to finish on, is healthcare worker exposures. I think that was one of the key things way back in the day when Ron started this. How many questions are you getting about needle sticks and mucous membrane exposures, and what's your general advice there?
Oh, I mean, we're getting thousands, thousands of calls per year. Um, and it's we want to raise awareness of post-exposure prophylaxis. We actually did a recent analysis where we found that actually not everyone is getting in the door to be able to have a conversation probably within that first day, honestly. So back to access, and it's interesting. The guidelines, I think, are shifting, so the emphasis is actually, if you're going to do PEP, get that first dose on board at least as quickly as you can. Get the information around the source to determine whether you're going to continue. So it's just shifting our thinking around PEP a little bit.
Yeah, and that's such a important resource because I mean I guess at large academic medical centers that have a lot of expertise on HIV, this is less of a issue because there's systems, but there's a lot of hospitals around the country that don't have perhaps even an ID consultant, and the availability of the warm line is such, well, that's more like a hotline, is such a benefit to those providers and to those staff folks, and I can't say enough good things about what you guys do.
Thank
We
you.
will have as part of this podcast sort of referencing to how to contact you guys, the numbers to call, so we don't have to repeat those necessarily right on air, so people can access it as a sort of addendum to the podcast link. Um, any final thoughts about your experiences and how rewarding this is to work in this field?
I'll just say that working at the NCCC is it's such a great place to work. It's really a collaborative environment. We have clinicians taking calls from many different backgrounds, and we really have the chance to run complicated questions by each other, to learn from each other, to learn with each other. And I think that enriches our consultations that we're able to provide to our callers, in addition to, keeping ourselves as clinicians really on top of what's going on in HIV treatment and prevention. So give us a call. We love to hear from you.
Yeah. And Carolyn, I'll let you have the last word.
Oh, yeah, no, thank you. I mean, well, just thank you for having us. But in terms of the sort of working at the NCCC, it's, I have to say, it's been a tough several years as providers. We know how real burnout is, and actually, it's to have a conversation and hear sort of from someone. You guys have been, it's been so helpful just to know that I can talk this through with someone who's kind and is willing to have this conversation with me. I mean, just hearing that immediate feedback just, I think, really emphasizes how meaningful our work is.
That's fabulous. Well, Carolyn and Lealah, thank you so much for doing this. It's quite informative and tremendous service that all your team provides. And I know that it's greatly appreciated by the rank and file of HIV providers, but also the general physician, nurse practitioner, APP community. I think they really appreciate it. So thank you for being with us.
Thank you for having us.
Thank you so much.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.